Dear friends, in this talk I will play a role of a contradictory view. Actually, I'm on side of fusion instead of mobility preservation. Is there a problem? Yes, there is a problem because mobility preserving surgeries claim fusion surgery, which is a classic for years, must be replaced with those surgeries. Mobility preserving surgeries need new implants and approaches, some of which may have greater risks and complications, and those new implants are expensive, and the industry campaigns and supports are shadowing the results of those techniques. And if you look at the PubMed search, then we have more knowledge on the fusion than any arthroplasty surgery. Even cervical arthroplasty, which is quite popular nowadays, has 4,900 hits on PubMed. What are the types of surgery? Probably you are confused about the types. These are the types. There are artificial discs, interspinous implants. I try to separately categorize them. Posterior dynamic fixations and total facet replacement systems. So these are the types. Probably nucleus replacement may be different than arthroplasty, because in arthroplasty, the arthroplasty tries to behave like a total disc. So there are many types in the many trademarks in the market, and cervical artificial disc is easy to apply and frequently used, and lumbar artificial disc needs a major surgery, and it has lost its popularity for some reasons. However, since it is quite easy to apply, cervical arthroplasty is very popular. Nucleus replacement is still in an experimental phase. There is no class 1 studies or multi-center studies. Moving off the implant is still a problem. You have heard a interesting presentation yesterday that we discussed if it is an arthroplasty. Reoperation rates are approximately 20 to 30%. I have been using PDN, prosthetic disc nucleus, many years before. Since it was moving, I was disappointed with the results, and it is not in the market. It is the company has taken it from the market. Interspinous distractors have been quite popular very recently, but now it has lost its popularity in the days. And they were claiming that by opening the spinal canal by some flexion, the intermittent neurogenic claudication will subside, and it can also be used for the back pain only. What about posterior dynamic instruments? Actually, there are mainly two types: ligament-based systems and screw rod systems. And the ligament-based systems are the pioneering ones, and the Dynasis graft ligament were the first dynamic fixation devices. If you look at the rod-based systems, they are semi-rigid systems. They allow some flexion extension. They restrict rotational movements. And by that restriction, they may provide some pain relief or back pain relief of the patients. The total facet arthroplasty, TOPS, was the pioneering facet replacement system, but it is not approved by FDA. Since now, I don't know if it is approved, but it's not. It is not in the market now.
It's in trials in the U.S.
Trials? Okay. Okay. So recent condition may be like this. Probably the total disc prosthesis and posterior dynamic stabilization are in the clinical usage. Interspinous distractors are in the clinical usage. Those have disappeared, and these are the experimental ones, especially nucleus regeneration and repair type of things are in the regeneration phase. Sorry. This graph is from a company brochure. They say that the spine surgery today, we make some discectomies and fusion surgery. In the future, they want us to replace them with total disc replacement or dynamic fixations. What is the purpose of surgery? The main purpose is to prevent or to diminish the adjacent level degeneration. And this is really one of the complications of fusion surgery. And if we diminish it, we will have a big advantage. So there are, however, many questions raising on that point. Do they really avoid the adjacent level degeneration? And which dynamic implant we must choose, whether arthroplasty systems or posterior dynamic systems, which patient and which indications, in addition to what, and we must have good class 1 studies. These are what we have to discuss. Is there a philosophical problem? Is there evidence enough for they are preventing adjacent level disease? We are having lack of experience because they disappear after a while and they are expensive. So, first of all, if you look at the famous Kirkcaldy-Willis phases of degeneration, we are having dysfunctional phase, unstable phase, and stabilization phase. Actually, by aging of the human, we are having more stabilization. The body itself tries to repair what is failing. If we try to preserve motion in that stabilization phase, we are taking a point against the body, the normal aging, and then it may not be very proper thing. So there is a philosophical problem. It is the mobility preserving surgeries is against the natural process. Fusion surgery is suitable with natural process, however, dynamic fixation is against that. And since heterotopic ossification, especially we see in artificial disc, is trying to fuse that segment, and somebody says that no, it doesn't mind, it doesn't matter too much. By the time it may get fused, but if it is fusing, then very expensive fusion technique. Critique against arthroplasty. Spine is not similar to hip and knee joint. Actually, that may be a good option in hip and knee, but in the spine, there must be something different. Surgery more technically demanding. Revisions are difficult. Wear out less than hip or knee. This is an advantage. MR artifacts still problem because we are having too much artifacts. and the patient selection is still a problem. For the evidence, there are especially good papers, class 1 and 2 papers, telling that the cervical artificial discs are somewhat better than fusion surgery, ACDF surgery. However, ID studies are all done by authors using those implants. Shadow of implant companies are still there. And heterotopic ossification, especially, the incidence is between 5 to 53%, more on long-term follow-ups, and this is still a big issue. Whether they are decreasing degeneration in adjacent segment. This is most recent study from 2018, this year, comparing high-class studies, 21 studies, meta-analysis. Cervical disc arthroplasty is better than ACDF in terms of adjacent segment disease and adjacent segment reoperations. However, this requires further validation and investigation in larger sample size prospective and randomized studies with long-term follow-up, the author's own conclusion. Adjacent level disease after disc arthroplasty may still happen, and the annual incidence of symptomatic adjacent segment disease in arthroplasty patients is about 3.1%. It's not very small number in 1 year. And comparison of ROM at the adjacent level at 2-year follow-up, this 2011 publication, and 100 cervical disc arthroplasty, 99 ACDF cases, no statistical difference in ROM at adjacent level. So you cannot tell easily that with cervical arthroplasty adjacent level disease is less than others. And in that study, actually, comparison of radiological adjacent segment disease, degeneration, sorry, not disease. Degeneration and disease are different terms. In 36 months follow-up, in total disc replacement group, it is 8.8%. In ACDF group, it is 10%. There is very slight difference. If you look at the ACDF studies, radiographic degeneration, adjacent level degeneration, is 32%. It's quite common. However, symptomatic disease is 6.3%. It's a very long-term follow-up study from 2013. So it means the adjacent level disease, especially in cervical spine, is not a big issue, even after ACDF. And it's not uncommon in arthroplasty. There are many types, and recent models are coming, and it causes a lack of experience because the companies are changing their type of instruments, and then we are not gaining too much experience, and then news are coming, and they are expensive. In general, in conclusion, it is still a gold standard, the fusion. And there are two critics for fusion. One is the non-union, the other one is adjacent segment degeneration. In conclusion, mobility-preserving surgeries are new advancement in degenerative spine disorders. Lumbar artificial disc has been out, and cervical artificial disc has been in. We need, however, expensive implants, and the cost-efficacy ratio is worse. If you look at the cost-efficacy, then we must tell you that it's not good to apply them in that pricing. They may have more confined indication